So now once the PBNA pass is done, now you can see Dr. Abhirami is removing the suction and we are pushing the needle out. And after pushing the needle out, we are introducing the stillet. And now you can observe, you can see the material which will come out through the proximal end of the needle. And we have Dr. Shweta, who is a pulmonary pathologist. She is going to make the smears and explain to you how the smears are made. So we pushed it with the stillet. Now we are taking a dry syringe filled with air and we are going to make sure that the samples are placed on the slide. So in this case, we have got a little scanty sample. Then after that, we are flushing the saline through the needle so that the sample can be sent for microbiological analysis. And again, we are flushing the needle with the help of air-filled syringe. And now Dr. Shweta will explain to you how we are going to make the smears.
So once we have got a material on the slide, we will just take another slide, put it perpendicularly, and we will use the pull apart technique to just smear this material onto the slide evenly with firm pressure. So we've got two slides here. And we put it in a fixative, which is around 95% ethyl alcohol, and we allow it for 5 seconds. And after that, we start the staining procedure. The staining procedure which we use here is rapid hematoxylin and mucin stain. We also use Diffquick and toluene blue stain sometimes. After fixing the slides, we remove the slides and put them in hematoxylin stain for 1 minute. Now after 1 minute of hematoxylin, we will have to take out these slides, give them a water wash, put it in eosin, 1 dip, pass it through graded alcohols, 80%, 90%, and then 100%. And then we have to mount it with the deep mix solution.
Now you can see our pathologist have made the smears, and now what we are going to do next is called as a rapid on-site examination. So if it is done by a pulmonologist, we call it as the PROS, but here we have an access to a dedicated pulmonary pathologist, Dr. Shweta. So now she will be seeing the slides in the microscope regarding the adequacy, regarding the representative sample, and whether we are able to see some atypical cells or granuloma in this case.
So the utility of ROSE would be to identify whether the adequacy is enough to diagnose whatever we are thinking in terms of according to the clinical diagnosis. Then in cases of CA lung staging, lung cancers, we can use it. Even in the peripheral lesions of the lung, we can target those lesions and identify what is the lesion. So in this case, it is the mediastinal lymph node 4R that we have targeted. And as I can see, there are a lot of cellular fragments which are showing mature lymphocytes. So it seems adequate. So the adequacy we measure by the number of lymphocytes which we see in high power field or high power field. We have to see at least 10 fields. So if they are more than 40, or we see a lot of anthracotic pigment covered cellular material, and or if we see malignant cells, then we say that this is an adequate number. So in this slide I am seeing that lymphocytes are present which are adequate. So it is looking like a reactive lymphoid aspirate. But since we are thinking in terms of a sarcoidosis picture, so we would advise to do a cryobiopsy.
So right now we have an adequate sample, but it has not yet clinched the diagnosis. So now we will go ahead and do the EBUS Intranodal Cryobiopsy. So right now we tried with EBUS TBNA, we were able to hit the node, but we don't have a proper diagnosis. So right now we are going for a intranodal cryobiopsy. So in our center, we do intranodal cryobiopsy by two ways. One, either using a 19-gauge needle or we use an electrosurgical knife to make a hole. Now what I am going to demonstrate to you is how to do an intranodal cryobiopsy using a puncture with a 19-gauge needle. So this needle is a 19-gauge needle. I am inserting inside the working channel of the EBUS scope, and I asked my assistant to hold the tip of the scope so that the scope doesn't move. You should make sure that you don't have any vessels in the vicinity while doing an intranodal cryo because it can cause bleeding. So we make sure that there are no vessels near the site of entry or near the site where we are planning to take a biopsy. And as for any other EBUS TBNA needle, now you are pushing the sheath out and observing that the sheath is in place. And once the sheath is in place, I lock the sheath channel and then I choose around 1 centimeter on the 19-gauge needle. We go in a guarded fashion because this has a wide bore, and therefore if you are not in the right place, there's a tendency to bleed. So we make sure that we go in a guarded way. We hold the scope in position and the skillet is out. Now I am puncturing the node with a 19-gauge needle. And once the needle is punctured, I have to see the needle in the EBUS scope. I request my assistant to do the jiggling and pull out the skillet and introduce a rack lock to make sure that there is no bleeding while doing jabbing with 19-gauge needle. Now you can see there is no bleeding. So I go in a guarded fashion, increase the depth of the insertion, and now you can see I'm taking some passes from the node. So the most important thing with the 19 gauges here, we are not using the 19 gauge to take a sample. We want to create a tunnel. So what we do is once we have taken adequate sample, now we are closing the suction channel. Now you need to closely observe how we do the jabbing. So we come out little proximally and we do stiff jabbing so that we break the capsule of the lymph node as well as to create the tract below the mucosa so that our cryo can easily pass through. So now here we are not trying to take samples, but here we are trying to create a tract which is different from what you do for taking the sample. I do multiple superficial jabs to make sure that an adequate tract is formed and the capsule of the lymph node is breached so that I can easily pass my intranodal cryo to get an intranodal cryo biopsy. Now you can see that I am making stiff superficial passes with an anticipation to create a hole. So now you can see that even in the bronchoscope, in the EBUS, you can see a tract has been formed with the help of the 19 gauge needle. Now I asked my assistant to provide the intranodal. For doing the intranodal cryobiopsy, we are going to use the 1.1 millimeter cryoprobe. So prior to using the cryoprobe, we check if the cryoprobe is functioning or not by the formation of the ice crystals with saline. And once we know that it is functioning, now I ask my assistant to hold the scope in position. And I am introducing the cryoprobe through the working channel of the EBUS scope. Now you can observe the cryoprobe coming out of the EBUS scope. And once I know that it is coming out of the EBUS scope, the cryoprobe is working by the formation of the ice crystals. Now I am asking my assistant to hold the scope in place and I am introducing the 1.1 millimeter cryoprobe. Now you will be able to appreciate the cryoprobe coming out of the scope. And once the cryoprobe is coming out of the scope, we make sure that we enter inside the node. Now you can see that the cryoprobe is inside the node, and I make sure there are no any blood vessels near the cryoprobe. And then I am holding the cryoprobe firmly And I am going to activate it for 4 seconds and remove the entire EBUS scope with the cryo end block. So 3, 2, 1. Now you can see that we have removed the assembly end block, and you can see the tissue material at the tip of the cryo which we are taking it inside the saline, and it will automatically delodge as the ice crystal formation decreases. Now we are taking it without crushing it, and we take this material and now we are giving it to the pathologist. But the most important thing to note is we should make sure that we go immediately inside to see if there is no evidence of any sort of a bleeding. So now I am putting my hose again. Can I have some silicone spray? I am going inside the airway to ensure that there is no evidence of airway bleeding. Can you hold this for me?
As we can see, we have got a big chunk of grey brown to blackish tissue here. Now we are going to make imprint smears from this through the imprint cytology technique.
The advantage of the intranodal cryo is you get a tissue so that you can subject it for IHC, and it helps in increasing the yield in EBUS DNA. It is not necessary to do intranodal cryo in all cases, but in this case, since we didn't have the granuloma, but we were having the representative material, we are going for the intranodal cryobiopsy. And now, after the imprint, whatever the biopsy material that is left over, now we are putting it inside the formalin so that it will be taken up for histopathological examination. Now you can see the block here. It is a very big chunk which we close for 4 seconds, and this should be sufficient for performing all sorts of immunohistological studies. We will go for our second pass of intranodal cryo. So right now the tract is already formed, so we need not keep doing the 19 gauge. We have measured where we have to enter, and we directly go to the site from where we need to take the biopsy. And now I'm asking my assistant to hold it at the site, and I'm introducing the Intrano 1.1 millimeter cryo again. And once we are in the site, now you can see once the tract is made, the cryo grows smoothly inside the node. But we should make sure that the cryo does not go to the distal margin of the node, because it has got a circumferential freezing effect, and that may increase your chance of vascular injury to the vessels surrounding your node. So we try to keep it either just below the capsule or in the middle of the node, and we make sure there are no blood vessels. And once we are sure there are no blood vessels, now we are going to freeze it for 4 seconds. So 3, 2, 1, 101, 102, 103, 104, and now we are removing it en bloc. And as you can see from here, we have the tissue, second part of the tissue with us.
So once we get a tissue after the cryobiopsy, we will have to make imprint smears and put it in alcohol.
So we are given further passes to Madam for analysis. So now we will see what we get in the diagnosis. So now you can see they are making the imprint smears.
The importance of imprint is that we will get the cytoarchitectural features as well as the diagnosis, and we will have further material for any ancillary studies that we have to perform on the tissue.
So now you can see our fellows going and checking the site after taking the biopsy to make sure there is no bleeding. That is most important. And this process, this entire rows or imprint takes just 1 minute. So it is a very valuable thing for us to get a diagnosis on table as well as triage our samples for further analysis. So now ma'am is going to observe this on the microscope. So let's hope that we have a diagnosis.
My cytotechnician is mounting these slides onto a DPX medium, and now we are going to see this under the microscope.
So generally when we do intranodal cryobiopsy, we try to take at least 3 to 4 passes, because especially when you deal with a case of cancer, you need a lot of tissue for this immunohistochemistry, molecular markers, and next generation sequencing. So it's always better to take a lot of samples. And now the pathologist is viewing the slides. Ma'am, what about the adequacy of the different slides, and are you able to see anything which is suspicious of a granuloma or malignancy?
Yeah, in the imprint cytology that I'm seeing here, there are lymphoid cell clusters as well as original foci which are showing suspicion of granulomas. So this will be confirmed on the histopathology, final histopathology report, which we will be generating in a day's time. But definitely this is an adequate sample, and if required, we can do special stains as well on this.
Yeah. So now we have, this is how your intranodal cryo helps in increasing your yield. So here possibly we have hit the site and we have got a granuloma, and most probably it should turn out to be sarcoidosis.